The World Health Organization has announced its plan to combat the mpox outbreak. Plus, why are COVID-19 infections spiking again? Hi, everyone. I'm Sean Calebs, and I'm sitting in for Anand Naidu, and you are watching The Heat. A new strain of the COVID-19 virus is spreading through the U.S. and other countries. We'll get to that in just a minute. But first, we want to talk about mpox. Earlier this month, the World Health Organization declared mpox a global emergency. This after reported cases and deaths surged in the Democratic Republic of Congo, then spread to neighboring African nations. There have also been isolated cases in Thailand and Sweden. The WHO is calling for a global response to deliver vaccines to vulnerable populations, and it is also seeking $135 million in funding to address this ongoing crisis. Nigeria just received its first batch of mpox vials from the United States. CGTN's Kalechi Emekalam has this report from Abuja.
Nigerian health authorities on Tuesday received 10,000 doses of the Jynneos vaccine from the U.S. Agency for International Development in Abuja, the nation's capital. Jynneos, a vaccine effective against both smallpox and mpox, approved by the U.S. Food and Drug Administration, is a key tool in Nigeria's fight against the mpox outbreak.
These vaccines are going to support the government of Nigeria's response to the current mpox outbreak, which has been declared, as we just heard, a global emergency by the World Health Organization.
The mpox virus is transmitted to humans through close contacts with an infected animal or person. The disease has been detected in at least a dozen African countries, including the tropical rainforest region of Central and West Africa. In Nigeria, there are about 40 confirmed cases and around 830 suspected across 33 states. The country's primary health care development agency plans to prioritize vaccine distribution to the most affected regions.
We are also going to prioritize states that have had the highest number of cases. Many of them are in the south, but of course we're going to have to work with the states to develop state-specific plans, to make sure that the vaccine is appropriately deployed.
The Nigerian government has rolled out a comprehensive vaccination plan addressing both safety and vaccine hesitancy. The World Health Organization has also reaffirmed the vaccine's safety and effectiveness.
The vaccine that Nigeria just received today is a safe vaccine. It has been used for smallpox, but they have shown some efficacy with the mpox. And we believe we should be informed by our science and not amplify misinformation. There is a committee that has been put in place under the SAGE, the Strategic Advisory Group on Immunization, which issue recommendation.
The World Health Organization's declaration of mpox as a global health threat has spurred action in Central and West Africa, with Nigeria at the forefront of the response. With this first batch of vaccines from the USAID, Nigeria aims to secure more doses to protect its population. Kelechi Emekalam, CGTN Abuja, Nigeria.
Okay, let's discuss this and much more. It's time to bring in our panel. Joining us from the UK, Chris Smith. He's a consultant clinical virologist at the University of Cambridge. And out of Virginia, Dr. Kate Tulenko, the founder and CEO of Corvus Health. In Maryland, Dr. Georges Benjamin. He is the executive director of the American Public Health Association. And in San Francisco, Dr. Peter Chin Hong, a professor of medicine and an infectious disease specialist at the University of California, San Francisco. I'd like to welcome all of you. I look forward to our 30-minute discussion here. Peter, I want to begin with you. Mpox has been around since 1970. We saw a spike in the number of infections in 2022, 2023. For an international audience who may not have focused enough on this or may not have been following what's going on chiefly in the continent of Africa, kind of bring us up to date what this is, where it is, and your concerns about it.
Yes, great question, Sean. I think the reason why we're concerned is that this has evolved since 2022. It certainly has evolved since the 1950s. And the way it's evolved is that in 2022, when it made everyone pay attention, it cut across countries to more than 100 countries around the world, and primarily amongst men who have sex with men. Right now, we have it not only amongst men, but amongst women, and more disturbingly, amongst children, which bears the brunt of mortality. And we are not really sure of how it's evolved, how its transmission has evolved. And so that's part of the reason why it's so different.
Yeah, and Chris, I want to get you to follow up on that, because this strand is different. And as Peter just talked about, children bearing the brunt of the fatalities in this, which makes a heinous disease even more difficult for people to cope with. Now, when mpox first appeared, it was either transmitted by human contact with affected animals or sexual transmission. But what we're seeing now is this kind of transmission by close human contact. Kind of talk to us about your concerns about that and just the unknown.
Well, we've known about this virus for many decades. Monkeypox, misnomer, because it was first isolated from monkeys, is actually an infection of small rodents, probably things like mice and rats that live in certain endemic areas in Africa. And periodically, the virus jumps out of that native species and it can get into bigger animals. It can get into monkeys and cause them to have monkeypox. It can get into us. And it's been doing that for decades, probably hundreds of years.
Wow.
And when it did so, it caused localized outbreaks in parts of Africa. But because the populations in those areas tended to be quite small, it tended to produce small, well-circumscribed outbreaks that fizzled out, most probably. And in Western countries, we occasionally picked up the odd case in a returning traveller, someone who'd been to an endemic area, had close contact with somebody who had the infection, and then they'd come home. But what we'd learned over the years was this was actually quite hard to pass on. It's not like COVID. It's not like Ebola, which is highly transmissible, or via the respiratory route. It's actually quite hard to catch this, and it does require very close personal contact, usually with the lesions on the skin, because this is a blistering illness and characteristically produces these blisters all over the body, which are crammed with infectious virus particles. And if you have close contact with somebody who's got those blisters, they come into contact with a breach in your skin or your mucous membranes, which can mean eyes, possibly you can breathe in some of the particles, then you can pick it up. But like all things that are driven by DNA and RNA, genetic material on Earth, viruses are no different. They all evolve. They follow the evolution process where, as things move through populations, they acquire genetic changes that may endow those things with new characteristics and better characteristics that enable them to operate better in the host in which they find themselves. So unsurprisingly, when we start to see very large numbers of humans catching this infection, driven by conflict, displacement, and the fact that we've got very high levels of population in the affected areas, we're seeing the virus evolving too and changing its modus operandi. And that's what's been documented this time, the fact that it's possibly a bit more infectious, but it's also widened its repertoire of people that it's transmitting among.
Kate, I believe Chris just gave a wonderful explanation of where we are right now, how we got to this point in time. But let's talk a little bit more about children, pregnant women, and those who do have weakened immune systems, especially people who have to be on the run, whether it be because of conflict going on or because of even something like climate change that is pushing people out of an area where they've always been. ABC News has reported that pregnant women have miscarried or lost their fetuses from monkeypox or mpox, and also some babies are being born infected with the disease. Now, in most cases, the deaths are happening to children under the age of 15. Why is that? And why are children so much more susceptible to fatalities than others?
There are a couple of different reasons why children are more susceptible. One is that children in these areas tend to have malnutrition, so their immune system isn't as strong. In general, also younger children, children under 5, their immune system isn't quite yet developed, so it's not as strong to defend it. And also, as was mentioned, the disease is transmitted through these pox, these lesions. And adults will see these lesions on someone else and not touch them, not come too close. But a child doesn't know what they are, and so they'll play with another child with lesions, or if a mother has lesions, she has to care for her child. She might not have the resources to place the child with another family for a while, so that will make her child get infected. So that's some of the many reasons. And also, in addition, in many very poor families, they can't prioritize a child's health.
Right.
So if a breadwinner is sick, they can prioritize that person's health and get them to medical care. But if a child is sick, they often just can't afford to take the child to medical care, which of course will increase the mortality rate.
And Kate, Chris also said something that I think needs following up on as well, because on the heels of the pandemic, virtually every story that I read says this is not like COVID. Do you think it's important to put that in there, to let people know that it's not going to be transmitted in this fashion and may not have the rapid number of mutations that we've seen with COVID?
I think it is, because people saw how fast COVID spread, how devastating it was. This is a very different disease, so there shouldn't be any panic. But we should be concerned, and government should invest the money and the resources into preventing it. As Chris pointed out, the more people get mpox, the more chances it will have to mutate, to spread more rapidly, or potentially combine with other viruses that humans have. When it was only in very small clusters, burned out quickly, there wasn't that much of a chance for mutation. But now, that we're starting to see it globally, there's a much more concerning chance for it to spread. And also, another cause for concern was how long it took to get the vaccinations to Africa. It's been 2 years since the outbreak that started in the Canary Islands, and it's just now that Nigeria and other African countries are receiving the vaccine.
And Georges, I want to talk a bit about the preventative care, because the United States is sitting on millions of these vaccines, and it is offered to donate 50,000 to the entire African continent. Have we missed an opportunity to kind of nip this in the bud?
Oh, absolutely. The fact that the WHO declared this as an emergency, we needed to behave like it was an emergency. That meant we needed to get the education into the communities faster, and we needed to get the vaccine out there much faster. Look, the amount of dose that we just sent to Nigeria, this was a 2-dose vaccine. So you've got to have the amount of vaccine that the community actually got. So they need to get more vaccine, and they need to get it much more quickly.
Yeah, and if we look at what the WHO has also said, that there really has been not a penny of donor money pouring into the continent of Africa to prevent this, to develop ways to fight this. Well, why is that? I mean, one thinks, and you don't want to say it out loud, but it's because this is a poor nation, and a lot of rich countries aren't looking at it.
Yeah, we don't think we're at risk. And the truth of the matter is, the best way to contain an infection is where the infection first emerges. We're in a global community, and while this disease is not as easy to catch from others, you can catch it. And as Chris said, it's certainly not the same as COVID, but once you get into a community where people are sharing it, either through sexual contacts, other close intimate contact, and on other objects like sheets, etc., this thing can spread pretty quickly through a community. So we're not immune. We're still at risk.
And we live in a global society. There's no question about that. Peter, we know that the vaccines are out there. The United States has a ton of them. Nations like Denmark has the Bavarian Nordic, Japan's KM Biologics. But the Bavarian Nordic is only for adults. And the other vaccine can be given to children, but it's more complex. Talk to us about how we got to this point. And it's hard not to read about this and read about how people suffer and wonder why there isn't more of an alarm going off, more people stepping up to aid.
That's such a complex issue. It's always thought as being other. Until you see it in the communities around you, you don't think of it as being of threat to the general public in Western countries. And until it affects Western countries, the aid doesn't pour in. I think that even in 2022, when it's among one population, which is the LGBT population, the rest of the population only felt at risk because whenever they got in touch and with that population, and that population was stigmatized. So I think you're seeing a lot of that playing into hesitancy to provide aid to countries that need it the most, to nip it in the bud. Prevention is never a priority. It usually is when you see it in your community and you want to treat it. Look at what's happening to COVID.
Yeah, it seems like the onus would be on nations such as the United States or the EU to step up and assist. But I guess the bottom line is money.
Yes, the bottom line is money.
Okay, Chris, let's pick up and talk about that. Now, we know that there are cases in Thailand and Sweden, but from what I read about that, it could very well have been people who were on the continent of Africa and then went back home or went to Thailand and went to Sweden. Several African nations simply don't have the information. They don't have the ability to develop this virus. We talked about the fact this does come down to money. I want you to hear what Max Lawson, the co-chair of the People's Medicines Alliance and head of inequality policy and advocacy at Oxfam International, had to say. Here's what he had to say.
They didn't want to share technology. They didn't want to open up their patents. They didn't want to threaten the profits of their pharmaceutical corporations. So we have the same broken system walking into another pandemic just a few years later is the definition of stupidity. And I think the European leadership played a huge part in being the problem there, just as they did in COVID-19.
Chris, it's not hard to misunderstand that, what he is saying. What are your thoughts on that?
Well, I think one thing to make clear to people is the vaccines that we use against monkeypox are the same vaccines that we used to use historically against smallpox. Now, they were last used routinely in the 1970s because we thankfully eradicated smallpox because it was exclusively an infection of humans and therefore we could wipe it out, and we did. And this meant that the vast majority of adults across the world were immune not just to smallpox but also to related viruses like monkeypox. And that has protected us secondarily for the decades since. But as those people have aged and some have passed away, we've grown a significant population now who are not immune at all, and that's reached a threshold and a tipping point, which is why we're now seeing, when we add to the mixture things like population displacement, conflict, deprivation, urbanization, and invasion of the tropics, which is probably the facilitating factor here, you get these outbreaks. And so we're in this effectively poisonous environment now where we have very few people who are naturally immune. We've got low levels of vaccine production and vaccine production capacity because we just don't need smallpox vaccines, or at least we didn't think we did, and they're not where the action is. So yes, we have to think about this very carefully, because while it may sound to some people sensible to stockpile vaccines in countries where there might be satellite outbreaks, like the United States, like the UK, like Sweden, Thailand, actually where the action is, where there are tens of thousands of cases, is at the moment in the Democratic Republic of the Congo. And if we want to be as effective as we can at protecting every other country on the world surface, we should intervene with what we do have where the action is right now, because that actually will massively reduce the likelihood of cases popping up anywhere else. And I think that message has got through to people, but it takes time for the wheels to turn on a number of different levels, one of them being getting vaccines manufactured and manufactured at scale and then shared at scale with the places where we've got a problem, because actually that will save us a lot of money and a lot of trouble and difficulties in the long run if we do that.
Well, Chris, we know that the vaccines are about $100 each. What is it going to take to get these nations moving in this direction and get a handle on the mpox outbreak?
Well, usually what happens is that we then start to see spillovers of cases into other countries, and those other countries then see this appear as a blip on their radar and they do something about it. Ebola was first discovered in the 1970s. 1976, the first case of Ebola was a school teacher. And when that was happening, and 1,500 people in small outbreaks for decades afterwards died of Ebola, not many people took much notice apart from virologists and other academics who thought it was an academic interest, but they couldn't persuade industry to take it seriously. 2014 came along, tens of thousands of cases and spillover into other particularly more moneyed parts of the world, and we didn't end up with just one vaccine, having not had one for 40 years. We ended up with a handful of different vaccines, some of which are very successful against Ebola. So I think that's the catalyst. It's when we start to see incursions of these things causing problems for the other countries in the world that have the vaccines, have the resources, have the know-how and so on, then it becomes a problem for them, or at least they think it's a risk for them, and then they do something about it.
Kate, Chris points out that there have been thousands of cases, there have been hundreds of deaths, and right now African nations need about 10 million of these vaccine doses. So far, I'm going to break the numbers down for you. The European Commission says it's going to donate 215,000. Spain is pledging 500,000 and actually urging all the EU to kick in about 20% of their stocks right now. The U.S. only donating 50,000 to the Republic of Congo and 10,000 to Nigeria. So if these nations have millions in stockpiles, I still haven't heard a good rationale for why they're not moving more quickly.
It is more the case of the vaccine inequity. And this is one of the many reasons why Africa needs to develop more of the vaccine capacity, because diseases like mpox, dengue, Zika, which tend to occur only in poor countries, are orphan diseases. And the more sophisticated pharmaceutical companies in the global north don't develop vaccines against them. So it really won't be until Africa has vaccine development capacity that we'll see vaccines created for this. And what I would recommend for these countries is to go with only one dose of the vaccine, because in studies that were done in the US, one dose covered 80%, and the second really only bumped it up 82 or 83%, so really not much of a big difference. And so since we're trying to prevent death and try to slow down the transmission, a one-dose regimen could possibly work.
Okay, George, is also, if there's a hint of good news, we know that there's going to be a scientific conference, virtual conference that's going to be held soon with the WHO, the Africa CDC, Coalition for Epidemic Preparedness and Innovations, and the National Institute of Allergy and Infectious are trying to find a way forward out of all this. What needs to come out of this virtual conference? It's only going to be a couple of days. How important is it going to be? And could this be perhaps a blueprint to finally corralling this, so to speak?
Yeah, I think a consensus, like Kate said, on how many doses of the vaccine would be most effective. I think a recognition that the high-income countries are at significant risk because, you know, we have great medical care in our countries, but one of the things that happens when you do that is you actually put people more at risk because we treat them for cancer chemotherapy, we put them on high-dose steroids. We do things for people for other diseases which actually reduce their immune status, so that if this disease came to this country, we would in many ways have more people at risk. So I think there needs to be some understanding of that, and then we need to increase the commitments that we have to getting these vaccines to the lower income countries.
George, while I have you here, let's talk about COVID also expanding. It's certainly something that gets everybody's attention. If you suffered through a pandemic for a number of years, new strains are coming out. Now we have mpox. What can you tell people? It's not the end of times, but how can you convince people, look, this happens. We just have to be careful and we have to follow scientific measures.
Yeah, COVID is now becoming an endemic disease. It's here. It's not going away. What we've seen over this summer, since the beginning of the summer, is we've had actually a doubling of the number of deaths, the number of hospitalizations, the number of ER visits. Now, granted, they're still relatively low, but there's not a day in the week that I don't hear about 2 or 3 people somewhere within my own orbit who have now become positive with COVID. The good news is they don't get very sick, but we need to maintain our vaccine adequacy and our vaccine status. And of course, we're now in the United States recommending an annual shot with the new strain. So we're really trying to encourage everyone to make sure that their vaccines status is up to date.
Indeed. Peter, let's talk about this new variant. I'm one, when this new vaccine's out, I want to be first in line to get this. I support the vaccines 1,000%. But I have a lot of friends who don't, and they don't want to get vaccinated. To what degree is that mentality affecting this ongoing endemic?
Yes, I mean, I think not all populations are equally affected, and I think that focusing on those who are older than 65 and those who are very immune compromised amongst the sea of everyone is potentially one strategy. Although it's simpler to say everyone over the age of 6 months get it. So I think that's kind of the dilemma. You know, how do you emphasize one population while offering it to everyone? And everyone has fatigue. And also, when do you get it? There's still many people who don't know that it's just given once a year now, and it's simplified, and people are just asking, how many times do I have to get it? So I think the messaging needs to continue to go out, the timing of when you need to get it, because right now we're having a surge, but we're really trying to prevent the winter. So should you get it now or should you get it in October? These are all things that are confusing to people in the population.
And Chris, I want to talk about long COVID as well, because so much is just not known about this. And now a new study says there could be a backdoor where where the COVID virus actually affects the brain. How concerned should people be about the long-lasting effects of this?
Well, it's still very early days, and research is still very much ongoing. The one thing we're not completely clear about is whether this is something unique and special just to these coronaviruses, this new family of coronaviruses that cause COVID-19, or whether had we had an outbreak of something similarly dramatic, but of a completely different virological persuasion, which affected billions of people around the world, we would have seen a similar pattern of post-infectious sequelae, as it were, long COVID caused by other kinds of viruses. We just don't know. We use this phrase long COVID as an umbrella term to describe a whole constellation of different syndromes and different symptoms that people experience off the back of that infection. And I suspect there are many different mechanisms at play in many different people who have many different kinds of susceptibilities. And so really, we can't distill this down into one syndrome with one mechanism, because it's almost certainly a mixture of things going on in different people with different vulnerabilities. And it's going to take time to work out what is going on in everybody, to therefore work out who's most vulnerable and who may suffer from what sort of condition and for how long.
Kate, we have about 30 seconds. Tell us about this new vaccine. What do we know about it? And why? How frustrated are you about the pushback of people who simply don't want to get vaccinated?
Well, I do think that moving forward, we probably should move away from mRNA vaccines, because unfortunately that is what is causing all the misinformation and the troubles.
Okay. Well, that was a quick, concise answer, Kate. Well done. Okay, I want to thank all of our panelists. Very interesting discussion. I learned a lot, but we're going to leave it there. I'm Sean Caleb's here in Washington, D.C. I want to thank all of you for watching yet another edition of The Heat.